I had to pick a specialty that I liked almost as much as ER, it would have to be PACU, post-anesthesia care unit. That's where I have worked for the past year or so. I just transitioned back into ER not long ago. It's got it kind of reminds me of the ER, just in the flow of daily care. You come in the morning, depending on where you work. Sometimes you're going to pre-op people and then send them off to surgery, and then you're going to recover them afterwards. But sometimes they have different hospitals do it differently, and there's actually a designated pre-op nurse, which is how most hospitals do it, the ones I've worked at. And you're going to have a designated post-op nurse, which will be you. PACU is considered critical care. A lot of hospitals do require that you have a year or two of critical care medicine, critical care nursing, before you get a job in the PACU. I had about 2 years of ER experience, which they considered critical care when I started. But interestingly enough, the hospital that I just got done doing a contract with this past November or December, they actually hired new grads, and they hired nurses from the floor. This was evidently a fairly new policy, and they did it to beef up their staffing numbers. But I mean, they had a lot of old school critical care nurses there as floats that would kind of watch over the new nurses and help in any emergencies. But a day in the life of a PACU nurse, you're going to get one patient initially. The guidelines for peri-anesthesia nursing says you should only get a new patient 30 minutes after your initial patient. So some places follow that to the T. Some places they'll give you a patient like 10 minutes after, which is not the best of practices and not the safest. But you get your first patient, you get them squared away, make sure they're breathing, attempt to control their pain. Sometimes controlling pain in the PACU really isn't a complete option. I mean, you're going to get their pain slightly under control, but you're not going to get their pain completely down to a zero. And we usually try to tell them that right when they get there, and reiterate it throughout the care in the PACU. If somebody comes out from a major back surgery, their pain goal may be a 5 out of 10, and they come out in like an 8 out of 10. So you're going to try to get them down to a 5. You're going to make sure they maintain their airway, they maintain breathing as you're giving them a lot of narcotics. You're going to use a lot of unusual drugs that you wouldn't use elsewhere in the hospital. We gave a lot of ketamine, we gave ketamine drips, we started lidocaine drips. They give several other medications to kind of chill people out after surgery, because a lot of people do not react well to anesthesia, and they kind of wake up and extremely confused and often combative. That happens probably, I'd say, maybe 1 out of every 10 patients or so. So not super frequent, but you'll probably get one patient like that every 2 or 3 shifts. And they're easily controlled with like Ativan or something. It just prolongs their stay in the PACU. The number of patients you're going to have per day depends on the acuity of your initial patients, but you're going to have probably anywhere from 3 to 7 patients a day in phase 1. If your hospital has a phase 2 PACU and you happen to float there, you can have up to probably 10 or more patients a day. Phase 2 is just where they send patients that are going home for outpatient surgeries, like a debridement of a finger or a nasal surgery, ear minor surgery, things that are simple most of the time. Occasionally, doctors will try to send home something a little bit more complex, and you're going to hold on to those patients for a long time. Nurse to patient ratio is 1 to 2 in the phase 1 and 1 to 3 usually in phase 2. PACU nursing is a great place to learn airways because, generally speaking, PACUs are ran by anesthesia. So when you start working in the PACU, where I initially started, you had to actually train under an anesthesiologist for a couple of days, learning how to manage airways and learning how to bag people who are getting really heavy sedation, learn how to put in oral airways and nasal airways. Did not learn how to intubate, but you watch a lot of intubations. As far as like patient acuity, you can have extremely high acuity patients in the PACU, just like in the ER. Patients can respond really negatively to anesthesia. You can have horrible things like malignant hyperthermia, and you got to know what to do during those things. For malignant hyperthermia, you give something called dantrolene or Dantrium. It's a special medicine that has to be mixed. It takes forever to mix, and in the meantime, you just pack them with ice, give them cold fluid, send them to the ICU as quickly as possible. You can have other people have heart attacks due to anesthesia. I've actually had somebody who had a MI under anesthesia. Thankfully, everybody's hooked up to EKGs during surgery, so they were able to quickly catch that MI, and I think he went directly to the cath lab from the PACU, if I remember correctly. This has been probably 3.5 years ago though, so he might have gone to the ICU first, I forget. You're going to have vented patients. A hospital I worked at, initially, they would have a lot of patients come out on what's known as a T-bar, which is basically a vent, kinda. They're still intubated, but they're breathing on their own, and they're just needing a little bit of time to wake up. So that was interesting. I'd never seen that before. I didn't know what the heck a T-bar was until I saw it. They don't use the vent at all. They just use humidified oxygen at 100%, and the patient basically just breathes on their own. Let me get into the parking deck here real fast. Hold on 1 second. Without getting hit or hitting a pedestrian or killing anybody in the process. That's a stop sign, sir. Thank you. Hold on 1 second. My boss doesn't watch this. I'm not supposed to park in this parking deck, but oh well. So yeah, post-op care is a whole lot of fun. It can get a little bit redundant and repetitive. It actually does get very repetitive, which is one reason I kind of bounce around from PACU to ER. If you've recovered 10 or 15 major back cases, you've recovered them all. If you've recovered a coli, you've recovered them all. 99% of all cases are pretty much the same. You're going to have a surprise every now and then, just like any facet of nursing. But if you're interested in PACU, I would suggest you get in touch with the manager at the local hospital and see if you can go shadow as a nursing student or shadow as a CNA, and see if you like it, see if it's something you'd be interested in. Because I really enjoy PACU nursing. It's a lot of fun. It's definitely not floor nursing. It's not ER nursing. It's its own little specialty, but it has parts of every nursing in it. So you'll learn literally everything. You'll learn how to deal with all sorts of drains. You'll learn how to deal with airways. You'll get to give all sorts of crazy medicines. I mean, it's really fun. It taught me a lot about critical care. Taught me how to manage vasoactive drips. So it's a good place to work. As far as going there as a new grad, why not? A lot of hospitals now have programs where they will train you for their particular specialty, and they train you how they want you to be as a nurse. So yeah, if you like my videos, give me a subscribe, and I'll see if I can get some more videos out in a couple of days. I'll see if I can make a video about my experience in the ICU. I worked in a small ICU, so my experience is going to be much different than somebody who would work at a level 1 trauma center or a level 2 trauma center or any sort of big hospital. But I'll tell you what it's like to work in an ICU in a critical access hospital. It can get a little dicey sometimes. Yeah, talk to you guys later.